Hello friends, I am Dr. Vaibhav Mudhale, Professor, Department of General Surgery, D.Y. Patil Medical College, deemed to be University Kolhapur. Today I will be talking to you about the subject minimal access surgery. So my talk will be divided into introduction of the topic, history of the minimal access surgery, what is the extent of the minimal access surgery, what are the advantages, disadvantages, how do you prepare the patient for minimal access surgery? What are the procedures which can be done by minimal access surgery and what are the complications? So to begin with the definition, it is minimal access surgery is application of modern technology to minimize the trauma of surgical access without compromising the exposure to the surgical site or patient safety. So there are various synonymous during the evolution of this procedure or minimal access surgery. People call this as a keyhole surgery. Some people call it as buttonhole surgery because it was done in through a very small buttonhole incisions. The actual term minimal invasive surgery or minimal access surgery is the correct term which we use. Rather than minimal invasive, it is a minimal access surgery or MAS is the correct terminology which is followed globally. Look at the history. It's not very old. In 1901, Von Ott first inspected the abdominal cavity and how the minimal access surgery started evoluting. In 1983, a German gynecologist Sem did first laparoscopic appendicectomy, and within 2 years, Erich Muhe, a German surgeon, did first laparoscopic cholecystectomy. And from then, the evolution started very fast, and now we are talking about the robotic surgery. 1987, first laparoscopic hernia. So this is how the basic surgeries started. People started doing. Lap hysterectomy was done in 1989. 1990, the minimal invasive surgery term was coined by this Wickman, Fitzpatrick, and Kusheri is the person who coined the term minimal access surgery in 1992. In 1993, first robotic surgery was performed. 1994, the advanced surgeries like cancer surgeries, colorectal surgeries, people started doing even in malignancies. In 2001, another minimal access procedure, that is NOTES, that is natural orifice transluminal endoscopic surgery, was introduced, and 2005 is the POEM, that is peroral endoscopic myotomy, which was done for the ecclesia cardia. And this is how the people have developed over a period of time, and this modern technology is the part and parcel of our surgery. So what is the extent? As a general surgeon, we do a lot of laparoscopic procedure, endoscopic surgeries, like it can be endoluminal or perivisceral, catheter-based surgeries, especially endovascular surgeries, and minimal invasive robotic surgeries. So the procedures which are most commonly done in our practice are laparoscopic appendicectomy, laparoscopic cholecystectomies, diagnostic laparoscopies, repair of all types of hernias, and as I said, peroral endoscopic for myotomy for ecclesia, even for acute abdomen due to perforations, and even solid organ surgeries like splenectomy, nephrectomies. So all these procedures can be done by using minimal access technique. The advantages, of course, it has many advantages. That is why it is in demand, or the people are started learning more and more about minimal access surgery, because we don't take a long incision as a traditional surgeon. This is done in very minimal size wound, so decreased post of pain, operative pain. Obviously, there is no big wound or large incision, so infection following the large incisions and complications like hernia and adhesions are comparatively very less, decreased recovery period, and improved mobility. So these are the main advantages which is successfully get by minimal access surgery. But there are certain limitations, like we have to operate depending on the remote vision. The surgeon do not have direct tactile feedback or sensation to his hand because the hand is outside the abdominal cavity, the instrument tip are inside the abdominal cavity, so tactile sensation or feedback is lost. And it's very important, it's very dependent on hand-eye coordination. This is the one technique every surgeon has to learn over a period of time for successful minimal access surgery, that is hand-eye coordination. It is very difficult to control hemostasis compared to open surgeries or traditional surgeries, as we can put lot of mobs to press, but here we have limited access, so it has to be a very meticulous dissection. Controlling hemostasis is a challenge. It relies on the new techniques, various techniques are developing, various instrumentations are coming up, and extraction of large specimen is another challenge. Suppose if I do a splenectomy, I cannot remove the spleen from a small incision like 10 mm or 12 mm board. So we use morcellators to keep the small pieces of that specimen, and then we retrieve through retrieval bags, or sometimes we can take small Fannin steel incisions for removal of specimen. Coming to the preparation, it is nothing different from any other procedures like an open surgery or traditional surgical procedures. We do all similar investigations as according to the patient's disease or pathology. So coming to laparoscopy surgery as proper, so it involves the placement of small telescope into the body cavity. The scope provide illumination of large tissue, target tissue, and convey a bright, magnified, high definition image through attached camera system, and it goes to the monitor, medical grade monitors. These images can be attached to medical record, so we can have recording of all the procedures stored with the radiological picture, achieving a communication system with radiologists, pathologists, and other consultants. So distant learning is also possible with this. This is the figure or picture, intraoperative picture, how the laparoscopy procedure looks like from outside. So this is the abdomen which is pending and draping has been done. There are a few trocars, and you can see the surgeon hand outside the body, and long instruments are going through this trocar inside the abdominal cavity. So the telescope gives you illumination, magnification, and image details. The limitation being it is a monoocular and it provides only the two-dimensional view of the body displayed on the video monitor. So limited field of vision is another challenge or limitation of this procedure. Laparoscopic images gives the surgeon a view of surface tissue. So the surgeon must adopt other methods to evaluate the tissue beneath the surface. This can be done by accessing patients with cross-sectional studies preoperatively like ultrasonography, CT scan, and MRI scans. How do you do laparoscopic procedure? The procedure is done by insufflation of abdomen by almost carbon dioxide, using 5 to 6 liters of carbon dioxide to create a working space. Allow lens to focus on target tissue. As I said, long instruments is inserted through an incision in the abdominal wall through an airtight trocars. These trocars or telescopic trocar can be around 10 to 12 millimeter size, and the instrument trocars can be about 3 to 5 millimeter size. These ports have a gasket that seal around the instrument to maintain the positive pressure and working space. Surgeons rely on texture and compressibility to evaluate tissue character and pathology. This is the pictorial presentation in intraoperative room, how the surgeon is standing next to the patient, and this is how after CO2 the anterior abdominal wall looks like a dome, and it gives you a working space where you can put in your instruments and you can look at the screen and operate, and this is called as hand-eye coordination. So surgeon hand is outside, his eyes are looking towards the monitor, and he has to coordinate his eye and hand movements to perform the procedure. This is intraoperative, another picture, how this instrument looks like. These are the long sticks and at the end of that sticks we have various instrumentation like graspers, scissors, and so many. So this can be performed after putting these long instruments. This is another picture of splenectomy. This is how the patient's position, left lateral position, surgeon is standing away from the target organ, all instruments are coming away from the target organ, and this is how the splenectomy specimen is retrieved through a specimen bag. This is another pictorial presentation of an hernia, inguinal hernia. The ports are placed away from the target area of surgery. So there is inguinal hernia, the ports are at around umbilicus and suprapubic region. So optimization, initially 10 mm telescope was used, now also we use, but there are mini or smaller scopes for smaller incisions like 5 mm, 3 mm telescopes are used, and obviously definitely they will provide with the same image quality, sufficient light to perform surgery. In mini laparoscopy even 2 mm scopes are used. This is another laparoscopic procedure which has come into the practice, that is SILS, that is single incision laparoscopic surgery. The entire surgical procedure is accomplished through one incision instead of multiple incisions required in traditional laparoscopic surgery. As I have shown in previous picture, there are 3 or 4 trocars which have been placed on the abdomen, but here only single incision is taken and all ports are inserted to the single incision. Single incision multi-port approach, or it can be a use of a single access device. There is one skin incision 1.5 to 2.5 centimeter length, usually at the umbilical level or trans umbilicus. After developing the skin flap, the fascia is cleared over the wide area all around. Either 3 5 mm or 1 10 mm and 2 5 mm trocars are introduced through the incision, which allow the laparoscope and operating instrument to be introduced and carry out the procedures. This is how the single incision port looks like. You take an incision at the umbilical level and through the same incision you put the all 3 trocars. These are the various devices for single incision. So one device is fixed at the umbilicus where you take the 1.5 to 2.5 centimeter incision, and this device is fixed at the umbilicus and you can put various trocars through this device. Another minimal access surgery is through an endoscope. So flexible endoscope is the instrument which can be passed through mouth. Usually we do it for during upper GI endoscopies. The ENT surgeons can put through the nose, nasal tract, and even through the rectum, that is colonoscope. Scope is advanced by deflecting the tip of the endoscope using wheel set at the handle, guided by image on the monitor. There are channels which can provide you access for the instrument to take a biopsy or do some other procedures, and lens can be irrigated or suction can be done through the scope. There are various channels for that. This is how the endoscopy room looks like. The surgeon is standing on one side of the patient, putting his scope through the mouth, and he has to look at the monitor and image and then perform the diagnostic or therapeutic endoscopic procedures. This is the intra-endoscope picture showing the polyp inside the bowel, and even procedures like polypectomy or snare polypectomies can be performed. Instrument that can be used with flexible endoscopes are instrument for the biopsy, punch biopsy for the tissue diagnosis, needles for the injections like bleeding varices in the esophagus, knives for incision, snares as I have shown you in the picture for polypectomies or foreign body removal, balloon to stretch the strictures in the GI tract, clips to occlude bleeding vessels or seal the perforations. There are various procedures which can be done during the endoscopic procedures like resection of esophageal, gastric, colonic mucosal tumors, per oral endoscopic myotomy for ecclesia cardia, gastrostomy, tube insertion for feeding purpose, or can be CBD stone extraction as you know in ERCP, natural orifice transluminal endoscopic procedures, endoscopic mucosal resection or endoscopic submucosal dissection for small mucosal tumors. Coming to the notes, that is natural orifice transluminal endoscopic surgeries, this is the access to body cavity is achieved without an incision in the body wall. So it is really a truly a scarless surgery. The access the target organ through the natural orifice like mouth, rectum, vagina. For these very long instruments, flexible instruments are used, or it can be combination of flexible and rigid long instruments. And this is how the pictorial presentation, how the notes are done. So few pictures are showing there is a scope going through the esophagus, through the stomach, and stomach is open at one place to access the target organ. The another scope goes through the rectum. We puncture the rectum and enter into the body cavity and access the target organ. And various procedures like cholecystectomy, appendicectomy, pelvic procedures can be performed. After placing a flexible or rigid endoscopes in nodes through a natural orifice as shown, an organ like esophagus, stomach and colon, which are perforated initially, endoscope is then advanced directly to the target tissue, and after the procedure is completed, openings are closed. But the major complications and failure of this procedure is peritonitis because of the non-healing of the closure of these natural organs, and that is the reason this is not picked up at present in practice. So people have tried this doing in a truly scarless procedure, but it has been stopped. Another procedure by minimal access surgery is this POEM, which is done for treatment for achalasia cardia. It is a natural orifice technique. It involves creation of long esophageal myotomy using a flexible endoscope. The steps being esophageal mucosa is incised, tunnel is created submucosally in the wall of the mucosa, esophageal wall, and then the long myotomy is performed by cutting the circular muscle fibers. This is the pictorial presentation of POEM. The first picture is injection of a dye, elevation of the mucosa in the esophageal wall. Second shows this incision of the mucosa and tunneling of the submucosa through the esophagus, crossing the G junction over the stomach. And ultimately, after doing myotomy, cutting the circular muscles fiber of the esophagus, the incision which has been taken on the esophageal mucosa is clipped or closed. This is the same pictorial presentation of the POEM procedure done by endoscopic way. Here, in cardiomyotomy, circular muscle is divided to a point distal to the lower esophageal sphincter, and secondly, esophageal mucosal opening is closed with clips. The complications being, major complication we come across after the POEM is gastroesophageal reflux disease. Another few procedures like EMR. Here, endoscopic mucosal resections are done for the smaller tumors limited to the mucosa, elevating the tumor of the muscularis propria with submucosal injection of a dye, creating one or more polyp by band application and remove the lesion similar to polypectomy. And this is the pictorial presentation how the EMR is done. First, you inject the dye in submucosa, elevate the mucosa and muscularis propria, and you apply a band, and that small tumor can be removed in total and taken for biopsy. ESD is a similar type of procedure but done for a longer mucosal tumors or larger mucosal tumors. Here the mucosa is elevated in similar way and there is dissection beneath the tumor in submucosal plane and remove the tumor en bloc. And this is how the picture of the ESD, endoscopic submucosal dissection. So advantages in endoscopy is a combination of flexible endoscope and ultrasound. Sometimes you can apply even ultrasound transducer at the distal tip, what is called as endoscopic EUS, endoscopic ultrasonography. It can be used in bronchial tree also, doing an endobronchial ultrasonography, or even in GI tract. It describes basically the use of the endoscopic ultrasound is complete thickness of the wall for staging of the tumor. Secondly, it gives us a better idea about the lymph nodes which are enlarged beyond the luminal lesions, and that can be biopsied or tissue biopsy can be taken through the endoscopic ultrasound guided. and adjacent structure, whether they are involved or free. So all this information, important information, we do get through endoscopic ultrasound. So it can be also combined with Doppler. Sometimes imaging nearby vessels can be evaluated, and so it helps in surgical procedures through using US by like a pancreatic pseudocyst drainage through the stomach. It permits precise targeting for delivering medication directly into the pancreas, liver and other organs. So coming to the end part of it, that is catheter based surgery. I am not going to go in detail. It's an endovascular procedure is used to occlude aneurysmal vessels. Imaging is provided by fluoroscopy. Contrast is injected to outline the vascular anatomy. Instrument can be threaded along the vessel, and narrow vessel can be dilated with balloon, and intraluminal stent can be threaded into the position guided by real-time fluoroscopy. This is the advantage of catheter-based surgery. Obviously, it has benefits like good results. It has recovery, reduce ICU stay, and usually, as you know, its uses are like in coronary artery disease, septal defect closure, dilate stenotic valves, and replace the cardiac valves. Now the most important newer technique which is developed in minimal access surgery is robotic surgery. Robotic surgery, robo-assisted surgery, same is the use of computer technology working in conjugation with the robotic system to perform surgical procedures. The term robot comes from Czech word robota, which means a forced labor. It was first introduced by Czech play writer Karl Epik in his fiction play, that is Rossum's Universal Robots. So this is how the robotic surgical or operating room looks like. The surgeon who is sitting in a green scrub is outside the theater or in the console room, and the intraoperative you see images, the processing equipments, endorist instrumentations, there is a surgical arm cart, and there is a high resolution 3D endoscopes. So this is how the robotic theater looks like. So surgeon is sitting away from the patient, and these are the special made robotic hand instruments. They are not like traditional laparoscopy instrument. They have a lot of movements in the instrument, as if you can look at the tip of that instrument, it is like a wrist of a surgeon. So it has all angle movements which can be done by our own hand, which is not there in a traditional laparoscopy instrument, which has a fulcrum effect. So this can be vanished or can be reduced by using robotic instrumentation, and this is how robot helps. Robot does not work, remember, autonomously, but act as an interface between the operating surgeon and patient. Surgeon sits, as I said, at a console in an ergonomic and comfortable position and uses movement of hand and feet to control the movements of the instruments and laparoscope in the patient. Surgeon can work from within the operating room or remotely. That is the advantage, as there is no direct contact with the surgeon and instrument. The surgical instrument, as I said, are wristed near distal tip, so the movement of surgeon's hand can be reproduced by the instrument without usual limitation or a fulcrum effect which is seen traditionally in laparoscopy instrument. Longer the distance, greater the latent delay, and delay of more than 250 milliseconds can have significant impact on quality of surgery. Theoretically, the surgeon can operate on patient at a great distance. However, trained personnel would still be required on the site to prepare the patient, insert the ports, dock the robot, change the instrument as and when required, and intervene to treat complication if it happens, unexpected findings that can be controlled, which cannot be controlled by robotically. So it's a very useful, as you think in a area where this war is going on, for the injured soldiers, hostile environment like space, outer space and deep sea, this robotic technology is definitely going to help. Recently, robotic surgery is carried out in conjugation with robotic assisted anesthesia also. It involves an automated platform where anesthetic agents are controlled using computer assisted device. that calculate moment-to-moment anesthesia doses in a closed-loop system. But drawback of robotic, obviously there is no tactile sense of tissue, very high cost at present, bulkiness of setup because it gets lot of gadgets, absence of data to compare the traditional laparoscopic surgery. Right now, robotic surgeries are used at various centers for mainly prostatectomies, heart surgeries, hysterectomies, ENT and general surgery. So this is the best robot available in the world, that is Da Vinci robot surgical system. There are many other companies, but this system is supposed to be a best one. And this is the picture how the surgeon hand, how he operates, and the console which is shown on one side. Obviously there is single port robotic system which is there, and this is how the single port robotic hand instrument goes into the body cavity. The future of the robot is flexible tip instrument for smooth and seamless movement. So as I said, like a surgeon wrist, the instruments are evolving many instrumentation which can act like a real hand inside the body cavity. Obviously, there are certain complications which one should know that about the minimal access surgery. It is not very safe unless you are experienced. Vascular injuries can occur, visceral injuries like stomach, colon and bladder, thermal injuries due to cautery, complications of pneumoperitoneum for long hour surgery like acidosis, arrhythmias, pneumothorax and air embolism. So this is in short about the minimal access surgery. Thank you friends.